Imagine using a standard, everyday personal lubricant, getting a mild allergic rash, and then discovering months later that this temporary reaction has permanently rewired the pain circuitry in your spinal cord.
Yeah, it sounds almost like science fiction, right?
Totally.
Yeah.
But today's deep dive explores exactly that because it is a biological reality for a staggering number of people. We are asking a really fascinating and highly specific question today. Can a localized vulval eczema, or just a simple contact allergy to something as benign as lube, actually trigger persistent chronic nerve pain?
And, the short answer is yes. And the mechanics of how it happens are completely changing our understanding of chronic pain. I mean, we're looking at a phenomenon where a temporary immunological response like an allergy bridges over and fundamentally alters the actual structural architecture of your nervous system.
Okay, let's unpack this. Because for anyone listening who has ever sat in a doctor's office in inexplicable pain, only to be told, it's just a recurrent yeast infection, or worse, that the pain is purely psychological, this deep dive is going to provide some serious validation.
Oh, absolutely. It's incredibly validating.
Right. So to get to the bottom of this, we've got a whole stack of sources on the table. We are pulling together clinical guidelines from the BSSVD, that's the British Society for the Study of Vulval Disease, some cutting-edge immunological research from the journal Brain, patient advocacy resources from Procela, and some really compelling surgical outcome studies.
Yeah, and all of these point toward a condition called acquired neuroproliferative vestibular dynia, or NPV for short.
NPV. Our mission today is to connect the dots between that everyday allergic reaction, something that just seems like a temporary annoyance, and this permanent rewiring of the nervous system known as NPV.
Exactly. And to understand how someone acquires NPV, we really have to start at ground zero, which is the environment where the initial reaction takes place. You just can't grasp the severity of this chain reaction without looking at the unique biology of the vulvar vestibule itself.
Right, because looking at the UB doctor's notes in the BSSVD guidelines, they emphasize that female genital skin is remarkably delicate, like incredibly susceptible to both irritant and allergic contact dermatitis.
Yeah, specifically type 5e delayed hypersensitivity reactions.
And just for you listening, when we think of allergies, we usually picture an immediate reaction, right?
Yeah.
Like someone eats a peanut and it immediately breaks out in hives.
Yeah.
So how does a type 5e reaction behave differently in this highly sensitive environment?
Well, a type 5e reaction is entirely different because it's mediated by T cells rather than antibodies. So, meaning it takes time to mount an attack.
Oh, so it's not instant.
Right, not at all. You might use a product containing an allergen for days, weeks, or even months before the immune system finally reaches a tipping point. And when it does, the inflammation is profound. And I mean, the list of everyday triggers coming into contact with this tissue is pretty extensive.
Yeah, the sources outline a lot of them, like preservatives like parabens or imidazolidinylurea, which are ubiquitous in cosmetics.
Yep, they're everywhere.
And propylene glycol, which is a foundational ingredient in tons of crucial personal lubricants. We're also looking at latex, rubber additives in condoms, fragrances, methylisothiazolinone in wet wipes.
Don't forget the active compounds in spermicides.
Right, like non-oxynol 9. Those are known culprits too. But beyond just chemical allergens, the sources also talk about the physical properties of the products themselves, like how some commercial water-based lubricants have an extremely high osmolality.
Yeah, that's a huge factor.
And osmolality is essentially like the concentration of particles in a fluid, right?
Correct. So when you introduce a lubricant with a high osmolality, meaning it has a much higher concentration of particles than the natural cells in your mucosa, physics basically takes over.
Like through osmosis.
Exactly, through osmosis. That hyperosmolar lubricant literally pulls the water out of your mucosal cells. So the cells dehydrate, they shrivel, and the structural integrity of the tissue just breaks down.
Oh, wow. So the mucosal barrier is physically compromised.
Yes, leaving the deeper tissues wide open to whatever chemical allergens happen to be in the product, which is why the BSSVD recommendations heavily favor switching to silicone or polyurethane alternatives, or at least, isoosmolar water-based lubricants, specifically to prevent this barrier breakdown.
So once that barrier is breached, those allergens basically get a free pass into the tissue, creating the perfect storm for a localized immune crisis.
That is exactly what happened.
Well, okay, I have to push back here, though, because, I mean, if I use a new laundry detergent and I'm allergic to it, I get a rash on my arm, I stop using the detergent, the rash goes away, and I move on with my life.
Right.
My arm doesn't develop permanent nerve pain. Plus, aren't these products explicitly designed for the most sensitive areas of the body? How does a reaction there differ from getting a rash on your arm?
It kind of sounds like, I don't know, planting a known invasive weed inside a perfectly balanced greenhouse.
I like that analogy. And what's fascinating here is that the answer lies deep in human embryology, because the tissue of the vulvar vestibule is not the same as the skin on your arm. It's not even the same as the skin on the outer labia.
Wait, really? It's not the same skin.
Not at all. If you look at a developing human embryo, the vast majority of our external skin develops from an embryonic tissue layer called the ectoderm. But the vestibule, that area immediately surrounding the vaginal opening that develops from the primitive urogenital sinus, which is made of entirely different tissue called the endoderm.
Okay, that's wild.
Yeah. There's actually a distinct anatomical border called Hart's line, where the ectoderm literally stops and the endoderm begins.
So they are fundamentally different building blocks of the human body, just sitting directly adjacent to each other. Exactly. And because the vestibule is composed of endodermal tissue, its immune and inflammatory responses operate on a completely different set of rules.
How so?
Well, this tissue is hypervigilant. It's evolutionarily primed to protect a critical entryway to the body, making its inflammatory response uniquely volatile compared to normal ectodermal skin.
Ah, okay. So that brings us to the inciting incident. You use a product, perhaps your mucosal barrier is compromised by high osmolality, and an allergen crosses into that hypervigilant endodermal tissue.
Exactly.
The immune system identifies it as a threat and launches a delayed type 4 inflammatory response. But to understand how that translates to permanent pain, we need to look at that animal study from the journal Brain, because here's where it gets really interesting.
Yeah, that study is groundbreaking. The researchers mapped out the exact biological chain reaction, whether the inflammation is triggered by a lube ingredient or even a recurrent fungal infection like Candida, the initial cellular response is the same. Immune cells, called mast cells, basically flood the area to fight off the perceived invader.
But wait, mast cells are primarily known for releasing histamine, right? I mean, that explains the redness, the swelling, the itching during an active allergy. But histamine doesn't cause permanent nerve mutations, does it?
No, histamine causes the acute symptoms, exactly as you said. But what the researchers discovered is that in this specific endodermal tissue, these activated mast cells are releasing something far more consequential alongside the histamine,
Oh,
a protein called nerve growth factor, or NGF.
nerve growth factor. I mean, the name implies it's doing a lot more than just creating a rash.
Oh, definitely. NGF acts as a highly potent fertilizer for a very specific type of nerve fiber. It targets C afferent nociceptors, which are the nerve endings explicitly responsible for detecting pain.
Okay.
So when the mast cells dump NGF into the vestibular tissue, it forces these pain nerves to physically grow, branch out, and multiply at an exponential rate.
Wait, how much growth are we actually talking about here? Like a few extra nerve endings?
No, the pathology reports from human patients with NPV show a staggering 10-fold increase in nerve density compared to healthy tissue.
10 times the amount of pain receptors. And the sources note that these aren't like buried deep in the tissue either. They're densely packed right up at the surface in the intraepithelial layers.
Right at the surface. Yeah.
That makes me think of a home security system.
Yeah.
So imagine you have one motion sensor in a hallway. An intruder, the allergen, trips the alarm. But instead of just ringing the bell, the alarm system panics and permanently installs 10 extra motion sensors in that one hallway.
That's a great way to picture it.
So now even a shadow or a speck of dust sets it off.
That analogy is spot on. And the situation is actually compounded by the type of sensors being installed, too. Because the newly sprouted nerves don't just exist in higher numbers. They physically overexpress specific pain channels, particularly TRPA1 and TRPV1.
TRPV1. Wait, I recognize that from dietary science. Isn't that the exact receptor that detects the burning heat from capsaicin and chili peppers?
Yes, exactly. So because these nerves have physically proliferated, and because they're coated in extra TRPV1 receptors, the entire region becomes exquisitely hypersensitive.
Unbelievable.
A mechanical stimulus that should merely register as light touch, like using a cotton swab, wearing tight denim, or using a tampon, is suddenly interpreted by the brain as a searing, burning pain.
Right. And there's a specific term for that, right?
Yeah, allodynia. Experiencing pain from a stimulus that shouldn't provoke a pain response at all.
So this entirely explains the transition from a temporary allergy to a chronic condition. The hardware of the vestibule has literally been rebuilt. But this raises a massive question for me. If the patient figures out they're allergic to the lubricant, they wash it away, they stop using it, Why does the pain persist for months or years after that?
Right. If the allergen is gone, why the pain? To understand why acquired NPV doesn't just stop, we have to look past the local tissue in the pelvis and examine the central nervous system. Because that brain study revealed that repeated, intense local inflammation doesn't just change the vestibule. It sends a continuous barrage of distress signals up the nerve pathways directly to the spinal cord.
How far up the chain does this signal actually go?
It targets the L6-S3 segments of the spinal cord, which is basically the major relay station for pelvic sensation. And when those spinal segments are subjected to this continuous bombardment of pain signals from the over-innervated vestibule, the spinal cord itself begins to physically adapt.
You're saying a localized skin allergy on the vulva ends up changing the spinal cord's software.
Through neuroplasticity, yes. The constant pain signals activate microglia, which are the immune cells of the central nervous system. They release inflammatory cytokines right inside the spinal cord, triggering long-term changes in gene expression related to neuroinflammation.
So the spinal cord becomes highly sensitized to any signal coming from that area.
Exactly. If we connect this to the bigger picture, we call it central sensitization. The spinal cord becomes hyperexcitable. It essentially learns the pain and locks it in. So even long after the original allergic trigger is gone, the spinal cord is maintaining that pain loop.
That is just mind-blowing, but I want to briefly pause here and make a really important distinction that the Procela patient advocacy resources highlight. Everything we've discussed so far is acquired, or secondary, NPV,
Right.
meaning someone was pain-free, experienced an allergic trigger, and acquired this nerve growth.
Right.
But there is also primary NPV, which is congenital.
Yes, primary MPV means a person is born with this localized overgrowth of nerves in the vestibule. It's an embryological defect from birth. And interestingly, because the vestibule and the umbilical cord both develop from that same primitive urogenital sinus endoderm we talked about,
Oh, right.
many people with primary MPV also experience severe umbilical hypersensitivity or belly button pain.
Wow. It is fascinating how embryonic tissue maps out our vulnerabilities like that. But for the countless patients suffering from acquired NPV, this biological cascade, I mean, from lube allergy to mast cells to nerve sprouting and spinal cord rewiring it must make navigating the healthcare system a total nightmare.
Oh, it really does.
You go to a doctor with burning pain, the original allergic rash is long gone. So the provider looks, sees no active infection, and just misdiagnoses it.
Right, they call it a psychosomatic issue, or maybe they just keep prescribing antifungal creams that do absolutely nothing for nerve proliferation, because the traditional diagnostic approach relies on visually identifying an active pathogen or a glaring abnormality. NPV represents a profound failure of that visual approach, because the structural changes, the extra nerves, are microscopic.
So how do specialists actually diagnose this and differentiate it from other types of pelvic pain? Because obviously they aren't taking a scalpel to every patient for a biopsy right out of the gate.
No. The frontline diagnostic tool is elegantly simple, actually. It's called the Q-tip test. The provider uses a standardized cotton swab to apply light rolling pressure to specific clock face locations around the vestibule. If that light pressure triggers sharp, localized burning pain, it confirms the presence of allodynia.
But wait, confirming allodynia just tells the doctor where it hurts, right? What if the pain isn't coming from surface nerve proliferation? Like, what if the patient has a pinched nerve deep in the pelvis, like pudendal neuralgia, and the pain is just radiating to the surface?
That's a crucial distinction. To rule out deeper nerve entrapments, specialists utilize the vestibular anesthesia test, or VAT.
Oh, how does that work?
They apply a concentrated topical anesthetic, like lidocaine, directly to the surface of the vestibular tissue, let it absorb, and then they repeat the Q-tip test.
Okay, and what does that differential tell them?
Well, if numbing the surface tissue completely eliminates the pain upon touch, the provider knows with certainty that the pain generator is located right there in the surface nerve endings. The issue is local. But if the surface is completely numb and the patient still feels deep, radiating pain when pressure is applied, it indicates the problem is likely an entrapment further up the nerve highway, because local numbing won't fix a pinched nerve near the tailbone.
That makes total sense.
Yeah.
So once a provider uses the VAT to confirm the pain is indeed localized to the vestibule surface, how do they treat it? The Procela resources are really adamant that you cannot use a shotgun approach here. You can't just throw generic pain meds at this. You have to target the specific mechanism of neuroproliferation.
And thankfully, the interventions are finally catching up with the science. In the lab, researchers have actually successfully halted the mechanism in its tracks.
Really? How?
By administering mast cell stabilizers like ketotifen fumarate, they prevented the immune cells from dumping NGF during inflammation.
Oh, wow. And didn't they also experiment with a compound called Ro-82750?
Yes, that one physically blocks the nerve growth factor from binding to the pain receptors. In those controlled models, they proved that if you intervene during the inflammatory phase, the nerves never sprout and that central sensitization in the spinal cord never takes place.
That is incredible. But those are preventative breakthroughs, right?
Yeah.
What about the patients who already have the tenfold nerve increase?
In the clinic, providers often start with targeted conservative topical treatments, the most notable being capsaicin.
Okay, which logically sounds like a terrible idea. Applying chili pepper extract to mucosal tissue that already feels like it's on fire.
I know, it sounds counterintuitive. And it is incredibly painful initially, precisely because those extra nerves are overexpressing the TRPV1 receptors that capsaicin targets. However, with consistent daily application over several months, the capsaicin essentially overwhelms those specific nerve endings. It depletes their neurotransmitters and eventually renders them desensitized.
Okay, but for many patients, conservative treatments simply cannot overcome a tenfold structural mutation. Which brings us to the surgical intervention highlighted in the sources. The retrospective study by King and colleagues on vulvar vestibulectomy.
Right, and the logic behind the surgery is straightforward. If the endodermal tissue has permanently mutated to harbor 10 times the normal density of pain nerves, the most effective solution is to physically excise that abnormal tissue.
Just remove it.
Exactly. The surgeon removes the hyperinnervated vestibule and gently advances the healthy adjacent vaginal mucosa down to cover the area.
Right, because the vaginal mucosa doesn't have the same hypervigilant endodermal properties,
Hmm.
so the new tissue isn't primed to overreact.
Precisely.
And the data from the King study on this procedure is some of the most compelling information in our entire source stack. They tracked over 200 women diagnosed with NPV. And what I found incredible wasn't just the success rate, but the absolute pathological validation these patients received.
Oh, absolutely. When the surgeons removed the tissue, they sent those specimens to the pathology lab for microscopic analysis. And a massive 97% of those surgical specimens were officially confirmed to possess the signature tenfold increase in nerve density.
I mean, try to imagine the psychological weight of that pathology report for a patient.
Right.
After years of being told to, drink a glass of wine, relax, or that the pain was entirely in their head, they are handed a piece of paper proving their pain was caused by a measurable, physical, tenfold structural mutation.
It's life-changing validation. And the clinical outcomes match that pathology, too. Of the women who opted for the vestibulectomy, 84% reported having mild to no pain post-recovery. Almost a third were completely, entirely pain-free.
Wow.
And when you contrast that with the compliant group who declined surgery and stuck to conservative or no treatments, 75% of those women continued to live with moderate to severe debilitating pain.
The vestibulectomy data really just proves that when you correctly identify the biological root cause neuroproliferation, and you target your treatment precisely at that factor,
Yeah.
the results speak for themselves.
It really demands a complete paradigm shift in how we approach chronic pelvic pain. We have to move past treating surface symptoms and start addressing the underlying neurobiology.
So synthesizing everything we've unpacked today, from the BSSVD guidelines, the brain journal, Procela, and the surgical data, can a localized contact allergy to a common cosmetic product like lube absolutely trigger persistent neuroproliferative vestibular pain? The answer is a resounding, scientifically verifiable yes.
Yes, it can.
It's a domino effect.
Yeah.
The endodermal tissue mounts a type IV hypersensitivity reaction to the allergen. Mast cells flood the area, releasing nerve growth factor. That NGF acts as fertilizer, causing pain-sensing nociceptors to sprout and multiply tenfold. And finally, that amplified pain signal physically rewires the L6S3 segments of the spinal cord, locking the patient into a state of central sensitization.
And this raises an important question for the future of medicine, really. It forces us to entirely reevaluate the physical dialogue between our immune system and our nervous system. We tend to view allergies and nerve pain as completely separate medical disciplines, but this research proves they are intimately intertwined.
Absolutely. And for you listening, if you or a partner are experiencing unexplained, provoked pain in this area, you must advocate for diagnostic precision. You have to look beyond temporary antifungal creams. Ask your provider about nerve level changes, ask for the Q-tip test, and inquire about the vestibular anesthesia test.
Be your own best advocate for sure.
Which leaves us with one final provocative thought to mull over today. If a localized temporary allergic reaction to a standard cosmetic product can permanently rewrite the pain circuitry in the spinal cord for this one highly specific area, could other mysterious, unexplained chronic pain syndromes throughout the body actually be the invisible ghosts of forgotten allergic reactions that quietly rewired our nervous system years ago?